To get correct diagnosis and accurate management in cases of so many swallowing disorders, then reflux disorders, esophageal reflux diseases, and diseases like Senger's diverticulum, you should have an exact idea or the knowledge of anatomy of esophagus. So let us continue with the anatomy of esophagus. So you know that esophagus is a muscular tube of around 25 to 28 centimeters length and around 2 to 3 centimeters in diameter. So for all practical purpose and also while doing esophagoscopy, we calculate the distance from the upper incisors. So the length of esophagus is important, and also the various constrictions, and then the curvatures to right and to the left, and also the various layers, the esophageal part of esophagus and the lower and upper esophageal sphincters. These are especially important from our side, ENT perspectives. So if we start from the upper incisors, 4 incisor canine, premolar and molar comes here also incisors. So actually we calculate from the upper incisors. Okay, so from this level the esophagus start from the lower border of cricoid cartilage, that is at the level of C6. Starts from here and it ends at the gastric end or the stomach end, and that corresponds to around T11. So this is a muscular tube which start from C6 vertebral level to T11, and it is around 25 to 28 centimeter. We can roughly take it as 25 centimeters long with a 2 centimeter in diameter, and it starts from the lower end of cricoid cartilage to the cardiac end. So it has got a cervical part, that is from lower border of cricoid cartilage to the sternal notch. Okay, sternal notch. So from the lower border of cricoid cartilage up to the sternal notch, this is the cervical part of esophagus, which is around 5 centimeter in length, and it goes through the superior mediastinum. Then from there up to the diaphragm, from the sternal notch up to the diaphragm, it is around 17 to 18 centimeters long. This is 5 centimeter. 17 to 18 centimeter long. It goes through both the superior as well as the posterior mediastinum, and that is the thoracic part. And from the diaphragm up to the cardiac end, lower esophageal sphincter, it is the abdominal part, and that again it is around 2 to 3 centimeters. So it starts from lower border of cricopharynx coming and joining with the stomach. Long tube of around 25 centimeters long and 2 centimeter in diameter start from the lower border of cricopharynx or at the level of C6 up to T11, and it can be divided into a cervical part, a thoracic part and an abdominal part going through superior as well as posterior mediastinum. As from our side, the cervical part and the upper thoracic part are of importance. Okay. So what are the structures or the layers of esophagus? That is important at the time of dissection during myomectomy. So we have a mucosa, then submucosa, then a muscularis propria, and fourth layer is usually it is serosa, but here the esophagus lacks serosa, and instead of that we have an adventitia. And this adventitial layer helps in surgical mobilization and also dissection of esophagus during surgery. Mobilization and dissection is easier because of adventitial layer, and this lacks a serosa. And coming to the mucosa, and this mucosa is non-keratinized stratified squamous epithelium. So it is non-keratinized stratified squamous epithelium, and it becomes simple columnar type as it descends into the descends towards the cardiac end or towards the stomach. So this is visible as the change in mucosal pattern, that is from stratified non-keratinized stratified squamous epithelium changing to simple columnar epithelium is very visible during an endoscopy and at the level of Z line. Okay, so that is visible during an endoscopy, that you can very clearly see. So mucosa, we can divide the mucosa into, first it is an epithelium, then lamina propria, and this lamina propria contain loose connective tissue and mainly the elastic fibers and gut associated lymphatic tissue. So gut associated lymphatic tissues are present in this lamina propria. And the next is lamina muscularis. And this mainly contains smooth muscle tissue and elastic fibers, and this lamina muscularis become thicker as it descends towards the stomach end or the cardiac end. Okay, so mucosa contain epithelium which is non-keratinized stratified squamous epithelium changing over to simple columnar epithelium at the Z line towards the cardiac end. The lamina propria which contains loose connective tissue and galt, and again lamina muscularis which contain smooth muscle cells and again elastin fibers. This submucosa mainly contain elastin and collagen fibers, then veins, lymphatics, and also the mucinous plexus. Actually, there are two nerve plexus in the within the layers of esophagus. One is the mucinous plexus in the submucosa, and another one is Auerbach's plexus, which is lying between the two layers of muscle fibers. Okay, so submucosa mainly contain elastic and collagen fibers, veins, lymphatics, and this mucinous plexus. Then this muscularis propria, muscularis layer, mainly there are longitudinal muscle fibers and circular muscle fibers. Okay, longitudinal and circular. Longitudinal muscle fibers are located superficially and it is thicker, and it is mainly forming from the posterior face of this cricoid. Okay, mainly formed by the inferior constrictor, and that is on the posterior part. Okay, so this is superficial, and circular fibers are located more deeply and it is more thinner. And so the lamina triangle and the Senger's triangle or the Killian's dehiscence are in relation with the longitudinal muscle fibers, which are continuation of the inferior constrictor muscle. Okay, so that these two muscle fibers forms the muscularis propria, and the adventitia in loose connective tissue. So because the esophagus has no serosa, infection and tumor, spread of infection and tumor is very easy, and also because the advantage of adventitia is that it facilitates, this layer facilitates easy surgical dissection and anastomosis. Okay, so these are the layers: mucosa, epithelium, lamina propria, lamina muscularis, submucosa containing elastin and collagen fibers, vein, lymphatics, and mucinous plexus. Muscularis propria containing longitudinal and circular muscle fibers, and again adventitial layer. Two important areas you have to remember in connection with the structure. So this lamina triangle and Killian's triangle. Lamina triangle is between the longitudinal muscle fibers and cricopharynges. Between longitudinal muscle fibers and cricopharyngeus muscle, and the Killian's triangle is between the again cricopharyngeus and inferior constrictor muscle. Okay, between the two fibers of inferior constrictor muscle. Both are in the posterior aspect. And diverticulum through Killian's dehiscence or the Killian's triangle is more common than a diverticulum through the laminar triangle. So laminar triangle between the longitudinal muscle fibers and cricopharynx, and this is more common. And Senger's diverticulum or the Pulsion diverticulum is commonly as short note, and also it can present as progressive dysphagia. That I will continue after this. I will explain after this anatomy. And Killian's triangle is between the fibers of inferior constrictor and the cricopharyngeus muscle. And another two important structures coming here are, one is an upper esophageal sphincter and next is a lower esophageal sphincter. So upper esophageal sphincter is mainly formed by the fibers of cricopharyngeus muscle, and then the lower esophageal sphincter, there is no definite muscle fibers acting to form the lower esophageal sphincter. It is mainly formed by the oblique muscles or circular fibers on the crus of diaphragm, and also the oblique fibers of the oblique smooth muscle fibers of stomach. And also the lower esophageal sphincter is acting because of the thoraco-abdominal pressure gradient, and also this esophagogastric junction angle. There is no definite muscle fibers at the lower esophageal sphincter. Okay. So upper esophageal sphincter is formed by the fibers of cricopharyngeus. The next is narrowing and curves. There are classically, every one of us know that there are 4 classical or anatomical constrictions in the esophagus and 3 other constrictions which happen more during diseases. So the classical constrictions are, at least you should remember the 4 classical or anatomical constrictions. So the first one, in all these we calculate take the distance from the upper lateral incisors. So the first one is at cricopharynx. That is, you know, it is a most narrowest part of our esophagus, and the second narrowest part in the body. The first narrowest part in the body is in the vermiform appendix, and the second is the cricopharyngeal sphincter area. That is at C6. It is around 15 centimeter. So when you do an rigid esophagoscopy, the first marking, when the marking reaches 15 centimeter, when it reaches 15 centimeter, you can think or you know that this is at the cricopharynx. Okay. And the second is where it crossed by arch of aorta. It comes here, aortic arch. That is at T4, and it is around 22.5. Roughly you can take it as 25 centimeters. Okay. And the third is where this is crossed by the left main bronchus. Roughly left main bronchus, and roughly it is at T5, and this will be around 27 centimeters, and the fourth one is at 40 centimeters, crossed by the diaphragmatic opening, where the esophagus crosses diaphragm. Okay, so roughly you can take it as 15 centimeters at the level of cricopharynx, then 25 centimeters from the incisor, upper incisor, 25 centimeter where it is crossed by the arch of aorta, and again 27 centimeter where it is crossed by the left main bronchus, and 40 centimeters at the diaphragmatic opening. So you have to remember this: 15 centimeter cricopharynx, that is C6, 25 at T4 crossed by the arch of aorta, and 27 at T5 by the left main bronchus, and 40 at the cardiac opening. That corresponds to T10. Okay, so these are the natural or anatomical narrowing or constrictions of esophagus. After narrowing, remember the curvatures, curves or curvatures of esophagus. It has got anterior curvature and also lateral curvatures. Okay, so anterior curvature obviously anterior or androposterior. Better terminology will be an androposterior curvature and also lateral curvatures. So the androposterior curvature I already explained. It follows the curvatures of the cervical, thoracic and abdominal vertebra. So that is why I told you in the cervical esophagus is in the superior mediastinum and the thoracic part goes into the superior as well as the posterior mediastinum, and again it follows the curvature of abdominal or the lumbar vertebra. We have two lateral curvatures. That is, in the strict sense, it starts from the lower border of cricopharynx and the indentation is slightly towards left side till it reaches the thoracic inlet. And in the thoracic inlet, it comes in the midline. Here it is slightly towards the left side, then it comes in the midline. And after that, after passing the to T7, after it is crossed by the left main bronchus, at T7, again it's slight deviation or it is, there is a slight curve or deviation towards the left side. Okay, slight deviation towards the left side. So one at the cervical esophagus, when it goes till the thoracic inlet, and the thoracic inlet it is again at the midline, and after reaching around from T7 to T11, it is going slightly towards the left side. That is why while doing the rigid esophagoscopy, once we have passed the T5 or the 27 centimeters constriction, we have to point the tip of esophagoscope towards the left anterior superior iliac spine. That is because of this left curvature. So there are two lateral curvatures towards the left side. The next important one is blood supply. Blood supply again we can divide into three areas: upper part, middle and the lower part. Blood supply we can divide into an upper, middle and lower part. Upper part you can remember as it is coming into the thyroid area. So inferior thyroid artery and left subclavian artery supplies the upper part. Left subclavian and inferior thyroid. And what about the middle part? Mainly the descending aorta is there. So supplied by descending aorta, branches of descending aorta and posterior intercostal. Okay. At least remember as branches of descending aorta and bronchial arteries. Branches of left gastric artery, then left inferior phrenic and branches of celiac arteries. Okay, let's remember, it will be easy if you remember the name along with the neighboring structures. So in the upper part mainly the thyroid, so inferior thyroid and left subclavian. In the middle part mainly the descending aorta and the bronchus, so branches of descending aorta and bronchial artery and also posterior intercostal artery. And towards the gastric part it's the left gastric artery, left inferior phrenic and celiac artery. And what about the nerve supply? The nerve supply, it is both parasympathetic and sympathetic. Parasympathetic, what is the parasympathetic supply? From which nerve? It is mainly from nucleus ambiguous through vagus. Okay, so it is the 10th nerve, and in the cervical part it is mainly the recurrent laryngeal nerve. Okay, recurrent laryngeal nerve supplies the striatal muscles. And parasympathetic in the cervical part is mainly from the pharyngeal plexus. And in the cardiac middle part, it is thoracic part, it is from the cardiac plexus. So pharyngeal plexus. Okay, so sympathetic is from pharyngeal and parasympathetic from nucleus ambiguous through 10th nerve, vagus nerve, and the cervical part is supplying the recurrent laryngeal. So that is about blood supply and the nerve supply. And the next important one is the relations in each part. So I'll deal mainly with the relation in the cervical and the upper thoracic part. Relations. In the cervical part, you know this anteriorly it is trachea and posteriorly comes the prevertebral fascia. And also thoracic duct is coming towards the left side of esophagus. And also one more, that is recurrent laryngeal nerve. Okay, so one is prevertebral fascia, that is posteriorly. Then what? Recurrent laryngeal nerve. So this recurrent laryngeal nerve, it runs in the tracheoesophageal groove and it is very close on the left side. So you should be very careful, especially on the left side. And also thoracic duct. Thoracic duct crosses it on the left side. And this thoracic duct at this part is connected to the Pirogov's angle. So you should be very careful during the cervical esophagectomy. And also one important tubercle, there comes the carotid tubercle, otherwise called carotid tubercle or chasing tubercle. And this is an important landmark during cervical esophagectomy. Relations of thoracic part of esophagus. As you know, it extends from D1 to D11. And the esophagus is going through the superior as well as the posterior mediastinum. We already discussed that. And this on the right side, this esophagus is continuing as the lesser curvature of stomach. And on the left side, you can see this esophagus coming and forming an angle with the greater curvature of stomach. So this angle with the greater curvature of stomach is called the angle of His. And also there is a mucosal tongue, a tongue of mucosa, which from the this angle it descends into the stomach, and that is called the Gubarov valvula. And these two are important in anti-reflux mechanism. And regarding the venous system, it begins in the submucosal plexus. I already told you that in the submucosa there is an abundant network of vessels and lymphatics. So the venous system begins in the submucosal plexus, submucosal layer. It perforates the muscular layer and it empties into the esophagus system. So on the cervical part, the veins are mainly going into the inferior thyroid vein. As I already told you, it is an inferior thyroid artery and inferior thyroid vein. And from the thoracic part, it is going into left brachiocephalic and esophagus vein. And from the abdominal part, it is going to the left gastric venous system, as it follows the arterial supply. And regarding the lymphatic drainage, they are present in every layer of esophagus, but predominant network is in the submucosal layer and also in the lamina propria. And from the cervical esophagus, it is going mainly into the internal jugular and upper tracheal. So from the cervical esophagus, it is going to the internal jugular lymph node and also the upper tracheal lymphatic system. Next important one is on sphincters of esophagus, upper and lower esophageal sphincter. They can be asked as short note, and also it is important in the management of reflux disease, esophageal reflux diseases. So sphincters of esophagus. How many sphincters? sphincters of esophagus. How many esophageal sphincter? We already briefly discussed on that. One is an upper esophageal sphincter and a lower esophageal sphincter. So the upper esophageal sphincter, it is formed by the cricopharyngeal part of inferior constrictor. It is at the cricopharyngeal sphincter area. So it is formed by the cricopharyngeal part of inferior constrictor, and this aids in swallowing. Okay, main role is in swallowing, and it has got a basal resting pressure of around 42 millimeters of mercury. Okay, and the recent literature tells that the upper esophageal sphincter is acting the main role in LPRD, laryngopharyngeal reflux diseases. Okay, so remember that it is formed by the cricopharyngeal part of inferior constrictor with a basal resting tone of 42 millimeters of mercury. And the second one, that is the lower esophageal sphincter. In the lower esophageal sphincter, there is no definite muscle fibers. Like the upper esophageal sphincter, which is formed by the cricopharyngeal part of inferior constrictor, there is no definite muscle fibers in the lower esophageal sphincter. And it is mainly formed by the encircling fibers of the right crus of diaphragm, then the oblique fibers of the stomach, and then a thoraco-abdominal pressure gradient, and I already told you that there is an angle of His. Okay, and also the Guberoff's valvula. Okay, so all these mechanisms are forming the lower esophageal sphincter. It has got a resting tone of around 10 to 20 millimeters of mercury, and it is around 3 to 5 centimeter long. Here it is 2.5 to 4.5 centimeter upper esophageal. Lower is almost the same, 3 to 5 centimeter, with the basal resting tone is less than that of upper esophageal sphincter. And the main function is prevention of gastric content or reflux of gastric content into the esophagus. So there are some factors which maintain the lower esophageal sphincter, like the physiological tone, then the length of intra-abdominal part of esophagus. So the factors which affect the or maintain the lower esophageal sphincter, what are they? They are important. One is the physiological tone, second is length of this intra-abdominal part of esophagus, then the pinch cock effect of the right crus of diaphragm. I already told you it is the tone is maintained, or the lower esophageal sphincter is formed by the encircling fibers of right crus of diaphragm. So the pinch cock effect of right crus of diaphragm, then pressure gradient. Thoraco-abdominal pressure gradient, then angle of His, that is esophago-gastric angle. I already told you that's a mucosal extension of mucosa into the esophago-gastric junction, that is the Guberoff valvula, oblique fibers at the gastric inlet, or the cardiac end of stomach. So these mechanisms will prevent reflux of gastric content into the stomach. So anything which will block or prevent the normal functioning of this lower esophageal sphincter will promote the reflux of gastric content, leading to a gastroesophageal reflux disease. Some drugs are there, like calcium channel blockers, drugs like calcium channel blockers, beta agonist, alpha blockers, and coffee, then food containing mint, alcohol, fatty meal, etc., and hormones like estrogen, then cholecystokinin, etc. So all these will lead to increase of reflux of gastric content into the esophagus. So to summarize, Esophagus is a 25 cm long tube arising from the lower end of cricopharynx, that is from C6 to the cardiac opening or the gastric opening of stomach, that is at T11. So C6 to T11. And we discussed about the 4 layers, the important relations of cervical as well as the thoracic esophagus, then the nerve supply, then venous drainage, arterial supply, and also the natural constrictions and the anteroposterior as well as the lateral curves of esophagus, and also the things which are important while doing a rigid esophagoscopy. Thank you.